Hello.
Hello.
How are you doing?
I'm okay.
Good, good.
I was looking for, I was trying to find the contract because I said I had to send an invoice after this, and I was like, I better look to find where it is.
Yeah, your guess is as good as mine. I'm just filling in today too, so I don't know any answers to that either.
Oh, shoot, it says it timed out. Oh, you know how many people usually attend this, or
Like when I've been on, there's a good like 10 to 20 usually. So I mean, it just depends on, I guess. And then it's recorded so people can access them later if they've registered too. So yeah, I'll start with like a few housekeeping tip information and then yeah, let you guys introduce yourselves and stuff.
and
So
are we sharing the PowerPoint? Are you sharing it, Nicola? Who's sharing?
I do not have it, so I'm hoping one of you do.
You
Hi,
need to share it?
Hi.
what's the matter?
PowerPoint, are you sharing or am I sharing?
Either one.
Does
You
it
want me to?
matter? Sure.
Oh, cold.
Where are you at?
Yes. Come in. Come in.
I don't know if I've said it before. Their contact today wants to know if they can do telemed instead.
Sure. Okay. Sorry, I'm presenting,
No
so.
problem.
So for the interest of time, I guess we'll get started. Hello and thank you for joining us today for today's Pediatric Mental Health Echo session on trauma-informed therapy and referral options in North Dakota. My name is Nikki Lifdalen and I will be your host today. I would like to go over a few housekeeping items and then Paula Condal and Nicola Herding will introduce themselves and we can get started. So if you could type your name and credentials, email and facility name in the chat box so we can keep track of everyone in attendance. We do ask as part of participation in this echo session, we ask that your cameras be turned on in order to build a more engaging community of practice. Please remember
You muted yourself.
I'm sorry, I muted myself. Was trying to put some in the chat and wasn't paying attention. Okay, just remember to mute when you're not speaking. And then if you have a question, please, you have two options. Just unmute and ask the question, or if you don't want to interrupt, you can utilize the chat and we can, I will monitor that and ask the question at an appropriate time. So I put the link to the pretest in the chat. If you could take a couple minutes to fill that out. I'll give you a couple minutes there. Everybody see the pretest? Sometimes it goes away or isn't there when people are joining. There's the pretest in the chat if you want to fill that out. There will be a post test towards the end of and an evaluation. Make sure to add your name and degree or position on those when they're entered towards the end of the hour. And following this session, you'll also receive an email that contains the link to the evaluation and the slides that were presented today. In order to receive continuing education credit for this session, you must complete the evaluation. And so, yeah, if Paula and Nicola, if you want to introduce yourselves and start the session, we'll get rolling.
Do you want me to start? My name is Paula Condal. I am the Executive Director of the Dakota Children's Advocacy Center in Bismarck, North Dakota. Children's Advocacy Centers are kind of hubs for kids to come through when there's been allegations of child abuse. And we provide many services, but one of them is evidence-based counseling. And so by practice, I'm also a licensed licensed professional clinical counselor and supervisor. And so I've been in my position for 24 years now. And I'm just excited to be here today.
Hi, everyone. I am Nicola Herding. I'm a clinical psychologist and the clinical director for the Treatment Collaborative for Traumatized Youth and the project director for Project REACH. I work at Sanford Health and Sanford Research, and my main work is with trauma and working with children and adults that have experienced trauma. And I'm excited to be here to talk about different therapies and ways that we can refer and make sure that our patients have access to evidence-based trauma treatment. So we want to make sure that we give credits to where credit is due. So we're thankful for funding from SAMHSA and the time that it takes to develop resources and materials that we can provide today. We've told you a little bit about ourselves already. Objectives today are to explain the need for trauma-informed therapy for all children in North Dakota, to identify 3 evidence-based trauma therapies for pediatric populations, and to learn about different access referral options for evidence-based trauma therapies for pediatric populations. So I'm sure that all of you are fully aware of the problem and the need, but we're going to kind of go through it a little bit. So the reality is that trauma exposure increases risk for PTSD, depression, anxiety, externalizing problems, and chronic health problems, which really necessitates early intervention and access to specifically evidence-based trauma treatment. We see the most benefit through research on evidence-based trauma treatment where children can really get better. And we will talk later about those specific evidence-based treatments and the research on them. The rates of trauma in North Dakota are significant, and there are various disparities that exist and are of concern. Although there are services available in North Dakota, many children and families experience a lot of barriers in getting those services. So if we look at the most recent data, because we're always a little bit behind we've got almost 17,000 reports to CPS with 2,800 assessments involving 4,700 suspected victims. And we've got 1,130 confirmed children as victims of maltreatment, and 1,500 children in foster care. So that's the data from 2022. And, I think that when we think about how big our state is, well, maybe that doesn't sound like a lot of kids, but it's still a lot of kids, right? It's still a lot of kids. Thinking about 26 and 1,000 kids, that's a lot of kids. And it's the reality is that it does exist in North Dakota. Children are experiencing harm. This is just maltreatment at the hand of somebody that's in a caregiving relationship. It doesn't include anybody that is hurting children that are not in caregiving relationships. And that's really important to realize that this is not including if it's a cousin that's hurting another cousin, or if it's an uncle that hurt a cousin that wasn't in a caregiving relationship. And so it's really important to realize that this is not the full picture of child abuse and sexual abuse and trafficking and those kinds of things. As I said earlier, there's a lot of disparities that exist. When we look at this picture here and we look at the ratio of child maltreatment, and we think about kind of the demographic makeup of our state, most of the kids in our state are Caucasian. And when we look at this pie chart here, 47% are Caucasian, but there's a big portion, 24% of these kids that have experienced maltreatment are Native American. And that shows us this disparities exist. Now, we could hypothesize a couple different things. We could hypothesize that maybe there are more reports. And so, therefore, we are seeing more data because there are more reports. But the reality is that there are disparities that exist. Whether there are more reports, whether there are more investigations, the disparities exist. So we do not have even representation in the data. When we look across North Dakota in terms of ACEs, so adverse childhood experiences, right? So typically we're looking at experiences of adversity in terms of like child abuse, so sexual abuse, physical abuse, neglect, emotional neglect, medical neglect, physical neglect, experiencing a parental having mental health issues, having a family member in incarceration, experiencing violence of a mother. About 40% of children have experienced at least one adverse childhood experience per a parent report. and 8% have experienced 3. Research shows the prevalence of traumatic events is higher among several racial and ethnic minorities and specifically rural children. A study looking at ACEs in North Dakota college students found 75% of American Indian students reported one or more ACE compared to only 49% of the Caucasian students. And so once again, showing that disparities, right? So we are seeing higher prevalences of trauma and adversity in racial and ethnic minorities and rural children. And that's a reality in our state as well. And another problem we have is our mental health shortage provider issue, right? So when we look at the map here, there are 4 counties that don't have a mental health shortage. But we have to realize that when we're talking about trauma providers, there's no map that specifically shows that. So this is a map in general of mental health provider shortage. It's not a map of mental health providers that serve children or mental health providers that serve children who've experienced trauma, right? And so there's likely still more shortage, right, than this. But this is kind of a general map. And so majority of the counties are fully or partially designated as mental health shortage areas. And 23 North Dakota counties have data that greater than 1,000 individuals per mental health provider. I cannot even like conceptualize that. More than 1,000 people per mental health provider? Like, and one county, 9,000 people? Like one provider? Like that's impossible, right? And that's crazy business. And so a reality is it's just limited access. And specifically limited access to specialty, right? Limited access for kids, and limited access to specialty treatments. And what does that mean for when a child experiences trauma and they need specific trauma treatment? It's harder to get to if you're living not in those 4 counties. So reality, you've got a family and you've got services, and there are just a lot of barriers, a ton of barriers. Okay, and all those barriers, whether it's the triple threat, right? Poverty, being a single parent, stress, whether it's contextual barriers, agency barriers, concrete barriers, transport, distance, insurance, time, weather, perceptual barriers, not feeling supported, stigma, not having a parent that's got a lot of difficulties and not wanting to take the child to mental health care, not feeling like mental health care is going to help their child, ethnocultural barriers, the belief that maybe that is not appropriate to ask for help or allow others to help you. And ultimately, all these barriers create a mountain, right? And it just kind of creates a situation where you've got this mountain that you can't really get to those services because there's so many barriers and it's so overwhelming and it's so daunting. So specifically Project REACH is a SAMHSA-funded grant that looks at reducing barriers, expanding access, advancing trauma care for children to heal in North Dakota. And one of the goals is to reduce barriers and increase access to trauma services throughout the rural and frontier regions of North Dakota with that equity care delivery as care considerations, and using intensive engagement and telehealth are as tools to try to reduce barriers and increase access, utilizing care coordination strategies with looking at Mary McKay's work and then trying to decrease barriers to telehealth by enabling at-home access with data and iPad loaner programs. Over to you, Paula, if I can get this to, there we go.
All right, so all of the programs that are subawardees of this Project Reach grant really want to make sure that we're providing services to youth in a thoughtful way. We want to make sure those who need the services most are getting it quickly. And you know that those, you know, just because you have trauma in your history or just because abuse has happened to you doesn't necessarily mean that you need counseling services. And so we want to make sure that we get kids into the services that they need and get them the help as soon as we can possibly do. And so we utilize this trauma screening tool. It's a fairly new tool called the Pediatric Traumatic Stress Screening Tool. It's very easy. You can scan it to get some more information about it. You know, the tool can be utilized in two ways. There's like a paper copy that you can administer to youth and to their caregivers. You know, there's instructions on how to score it and then how it rates the youth. Or there, if you wanted to be a part of like a collaborative, they're collecting data on this. There is an electronic version as well. That if people are interested, I can connect you with the people who are doing this. But the electronic version is really nice because it not only scores it for you, it tells you the next step. So if a kid has concerns for suicide ideation, it'll pop up a thing that says, you know, this kid, there's concerns for suicidal ideation, please do the Columbia. And then it has you do the Columbia. And then based on the screening tool, it categorizes kids into three areas. Basically low and medium high concerns. And like, for instance, the low is you use a protective approach. And so you might do some psychoeducation. You might teach them like what they call a brief in-office intervention, which is basically teach them a quick coping skill while you have them in your place. And then you might do some continued monitoring, but those are the kids that might not need counseling at this point, right? And so it tells you exactly what to do. And it's a really nice step-by-step tool to be able to screen kids to know what services that they need. And they have that in the paper form as well. It just takes, it's a little bit more cumbersome to score something paper wise, but it's a really nice screening tool that we all started using. So just a resource for you. If you wanted to go to the next slide. So we're going to talk about evidence-based therapy and why we use evidence-based therapy. There's been more and more and lots of research now in the last 20 years that have shown that, you know, typically, and we still get this question a lot today, people will call me up or people will interview for a position here, or even the news station will ask to do a story on me, and they'll assume that we're doing play therapy for kids. And, but sorry, my phone, let me silence it. There's been a nice body of evidence now that shows that if you compare play therapy or other non-directive mental health therapy approaches to directive approaches that have been studied and have shown to be effective, that always the directive approaches have come out on top as far as reducing symptoms, the reduction of symptoms for longer term, and kids getting through treatment quicker. So that means that kids can get back to their normal lives. They don't have to miss as much school or, you know, miss as much sports or band or whatever they might be into because they're getting in and out of therapy quicker. They are healing, and that healing or that symptom reduction is lasting longer. And so we always want to give kids the best option or the best chance at having from healing from this horrible experience that they have, and get them back to the life of just being a child and enjoying life. And so if we can do that for them, that's important for us to do. And so we know that along with that evidence-based therapy, it's really important that we have specialized training so that we're meeting fidelity of those evidence-based practices. And then along with being able to provide that, having training for that, then we want to make sure that we create access for kids for those therapies, because if a kid can't get to you, we're not really being helpful to them. And so that's what this grant is all about, is helping with that access and creating resources for these kiddos. Next slide. So I'm just going to go, there's a lot of acronyms, so I'm just going to go over some of the evidence-based therapies that we provide at our centers. There's child parent psychotherapy, which is something I don't provide. I provide much of these, but I don't provide this one, but it's for younger kids. It's a child parent model. So you're in there with the child and parent, and it's kind of a coaching model where you're coaching the parent to build nurturing, to increase the parental skills, and help that, have that parent help the child through the trauma that they're dealing with. It's effective on multiple types of trauma, not just like sexual abuse or physical abuse. It's effective. It's been shown to be effective on all types of trauma. It reduces trauma symptoms such as attachment and security, positive child attributes, and improves the child's cognitive functioning as well. And like I said, it really improves those parental skills, and helps the parent really react better to the child. Very similarly is the parent-child interaction therapy. The difference between the two is one, the child-parent psychotherapy, the CPP, focuses more on attachment and nurturing. The PCIT focuses more on behavioral intervention. And so the PCIT is a therapy. Again, it's a parent coaching model. It's for kids who are 2 to 7 years old. They do have a toddler model, but for most families, we do the 2 to 7. The caregiver is involved. They come to the sessions. They're in on the sessions. We do this one at our center, so I know much better, but I can tell you that I think that one of the unique things about it is that oftentimes, most of the time, the therapist is not in the actual room with the child and the parent. The child and the parent are in their own room, and they are on video camera. The parent is wearing an earpiece in their ear, and the therapist is watching just like over a Zoom meeting like this. And they are coaching the parent to react better to the child's behavior. And so they might say, did you see the child winced when you said that? Maybe give them a praise, those types of things. The child seems to be asking you to engage and play with them, and giving them some coaching skills to react better to their behavior. Again, it's effective on multiple types of trauma. It reduces the behavior symptoms and the trauma symptoms, and it reduces that parental stress and their concerns. So it increases the competency of the parent to really be that parent therapist or coach that parent to help the child through this situation. These are the ones for young children. If you go to the next one, Nicola. So CFTSI, the child and family traumatic stress, is for it's a very short-term evidence-based treatment. It has lots of efficacy. The research on this has been, it's a newer model, and the research on this has been very overwhelmingly positive. It's for kids 7 to 18. There as well a caregiver component. And so it's for kids who have had trauma, but they disclose right away. So within those 45 days, they disclose, but they can have multiple traumas. But what we want to do is try to get to that child and that parent as quickest to the trauma as possible. And if we can get to them and teach some good skills and monitor their trauma symptoms, they've found that this can be a very short-term treatment. I believe it's 6 to 12 sessions, where, again, you're teaching skills, you're encouraging the parent to model and reinforce those skills at home. And because you're getting to it quickly, the research shows that this is an intervention that prevents the development of PTSD, because you're getting to the child quickly enough. So it reduces those trauma symptoms, prevents PTSD, and it improves that family communication and reduce parental trauma symptoms as well. Next slide. So there's AFCBT. There's a lot of acronyms in here. So this is for kiddos ages 5 to 17. This is really more of it's a child-parent-child model. And it's really for high conflict families, or for where there's been physical abuse and that child is returning to the home or residing in the home where the person who abused them is at. And so we want to teach a lot of parenting skills. We want to teach lots of communication skills. We want to teach affect regulation skills and trauma reduction. So what happens in this therapy is that the child goes to some sessions alone. The parent is going some sessions alone. So the parent is specifically looking at what are their deep values and beliefs that they hold based on parenting and how were they parented and how do they want to do differently with their kids. And then we teach skills based on that. So while the caregivers are learning those types of things, the kids are really doing some trauma therapy. They're addressing their emotions about this and their feelings. And I'm sorry, I'm talking with my hands, so now it looks like I'm raising my hand. So the kids are learning some things, and then at about midpoint to the therapy, in between there's some parent and child sessions. But then when they start getting together, we really work on communication. There's a piece where the parents do a clarification letter, or really a letter of taking ownership of what's happened in this situation and what they're going to do differently to prevent this situation from happening again. It's a very intensive therapy. It's one of those therapies that I will say that if you can get it, when you get a family through it, it almost feels magical because you could really see the long-term change of behavior and the effects that has had in the family. But again, it improves trauma symptoms, it reduces the externalizing behavior, those anger, behavior, anxiety, improves social competence, that self-safety. And it improves those service systems. So like that abuse risk, family dysfunction, safety. And so, again, like we've seen this kind of really work wonders on families, but it is a very intensive therapy. And you do need people who, like, there's a lot of, oh, my mind just went blank, but there's a lot of, in the beginning of like a decisional balance with families of like, having them review and just like helping them make the decision that this is important for their family, so they're committed to the process, because they really have to be committed to the process for this to work. And so you do a lot of motivational interviewing type things at the beginning to get the family committed to doing this together. So next slide. Then there's TSCBT. I always say TSCBT is the gold standard of doing evidence-based therapy with kiddos who've been traumatized. It has the most researched studies on it. It's just very versatile. It gives you, a lot of people, when they first are introduced to TSCBT, they think of it as a manualized treatment, and it is in some sense, but it really gives you the chapter headings pretty much. But how you do those chapter headings, like it tells you that you're going to do some affect regulation, right? You're going to talk to the kid and the parent about feelings and how they experience those and what do they need when they have those feelings, but it doesn't tell you how to do that. So it's very versatile in that sense. It's for kids aged 3 to 18. There is that caregiver involvement. You try to involve the caregiver in every session, at least the last 10 to 15 minutes of each session. Then there are some sessions that you may do with the caregiver alone. And then there are some conjoint sessions where the child is sharing a trauma narrative letter. Again, it's effective for multiple types of trauma experiences. It's shown to reduce trauma symptoms, externalizing behavior, depression, PTSD, all those kinds of things. It does improve, because of the caregiver component, really, they also have shown that it improves parenting skills and support and reduces that caregiver distress. And the other piece is because you are including the caregiver in that last 10, 15 minutes of each session, and you're teaching the caregivers the skills that you're teaching the kids. It's also been shown to kind of almost, in some ways, be a very light, vicarious treatment or counseling for that parent as well, because the parent are encouraged to learn those skills, practice those skills as well. So when a parent is really struggling, it can help them as well with their own emotional and cognitive needs related to the trauma. They do have enhancements to the model, lots of enhancements that you can get additional advanced training on, such as doing TFCBT with the LGBTQ plus population. There's a Native American enhancement. There's one on trafficked youth, and there's many others. There's one on complex trauma. There's one with working with African American populations, and so forth. Next slide. So we wanted to give you guys referral options for trauma therapy across the state, because as Nicholas said, there's this huge shortage area all across the state, right? There's shortages of even though like I reside in Bismarck and Nicholas in, the largest city of the state, there's still lots of wait lists to get it to kids to get trauma treatment oftentimes. Or there's a difficulty finding people who use evidence-based practices. And so if you go to the next slide, we just wanted you to know some resources. And so the top three, the three sites that are at the top are Project Reach organizations. So these are organizations that are sub-awarded through the Reach grant that all have the specific trainings or some of the trainings that I just went through. They all offer this to children's and the caregivers. Not every site offers every single one of those evidence-based practices, but somebody at those sites, like all those evidence-based practices are represented somewhere along those sites. But outside of that, we wanted to give you guys information as well. There is a website that you can look up trauma therapists in North Dakota, and you can put in your city or county, and it'll tell you where trauma therapists are located who've had training across the state. It's the Treatment Collaborative for Traumatized Youth. They offer this free website, and you can go to this URL and type in on the search engine where you're located or what you're looking for. Say, even if you say, oh, there was this therapist Cindy that I heard of, and you could put Cindy in and it'll show you any therapist with the name of Cindy to be able to find a therapist across the state. And so I think this is just a really robust website. It also tells you, if you can kind of see, it tells you if it's outpatient, inpatient, where they're located, the agency name, their website, so you can look to contact the therapist, but then it tells you the treatments that they are trained in as well. So you can kind of see Alana Johnson has been trained in TSCBT, right? There's an Alexandria Schultz, she's trained in TSCBT, and then TSCBT via telehealth. TSCBT via telehealth is one of those I can't think, I just said the word, enhancements for TSCBT, right? So that's one of the things that people can do. There's Alyssa in Grand Forks. She's trained in ASCBT and Sparks. Sparks is one that we didn't mention in the list, but Sparks is, and I'm not going to get the acronym right, so I'm not going to try, but it's a group treatment for kids who live in complex trauma. It's and so it's we do it in, oftentimes we do it in schools for junior high or high school, but we also do it in outpatient. It's a program that both Nicola's site and my site offer, as well as Fargo site, we all offer Sparks. But it's a group treatment, 16 sessions, plus there's assessment sessions and those types of things. But it's really for those kiddos who've had complex trauma or who are still living in like a complex trauma home, like their household might still be, like a lot of kids in my group, like their parents are absent, or they're, there's like alcohol and drug use present. And we're giving them skills to kind of cope with those situations, and a lot of like DBT and mindfulness skills to help them with self-soothing and distracting and communication and identifying things that mess them up, their thoughts that mess them up, and those types of things. So another treatment that is offered as well. So we thought we'd go, if you want to go to the next slide. In the next 10 minutes, we thought we were maybe longer. We thought we would just kind of talk about a couple of cases where we've utilized these treatments to just kind of show you like the difference that they've made. Do you want to share yours first, Nicola? Or?
You go ahead since you're talking.
All right.
Unless you want a break.
Well, it's okay. When Nicola and I were planning this, the first kid that came to mind actually was one of my very first telehealth kids. And I think that it's really important to, when you're thinking about reducing barriers and increasing access to youth, telehealth should always be an option in your mind to think about, because we have so many kiddos across the state that can't get to a therapist, not only because there's wait lists and such, but even if there wasn't a wait list or when it's your turn to get in, you might live 3 hours away. And so if you live 3 hours away, you're not going to be able to, you might be the most committed person on earth and say, I'm really going to, this is important to our family and I'm really going to make this work. But the reality is to drive 3 hours each way every week to get your child healing is near impossible. It's expensive. You need to have reliable transportation. You have to have good weather. You have to have a very understanding employer or be self-employed to be able to do that. Your kid's going to miss an entire day of school every week. you know, there's just, it adds barriers upon barriers to be able to do that. And so this was a kiddo that I had was referred to. She was 12 years old, but looked much older for her age, and had, you know, acted like, you know, tried to act anyway, like she was like 16. She was autistic. She had tons of other behaviors. She was diagnosed with oppositional defiant disorder. She was kicked out of school on and off for very violent behaviors like beating kids up in the bathroom, you know, just exploding in class, running away, those types of behaviors. And then the reason that she was specifically referred to me was because she had problematic sexual behaviors. She would corner kids in the bathroom and touch them, and had some charges on her for that. There was lots of concerning things with her. And her mother was very overwhelmed. They were at a loss of what to do. She was seeing a therapist locally in her community that was not trained in working with kids with problematic sexual behaviors. And so that's another evidence-based treatment that we provide. You know, when her mom called me to set up an appointment, she was really at her wit's end. And like I said, very gung-ho, like, we are going to make this work. I know it's a long drive. We are going to do this, though. This is important to my kid. This is tearing my family apart. You know, she was worried that the kid was going to not have an education and not have a future. She did not have friends. She had very poor social skills. You know, at that point, it was just really like a lot of fighting and locking, not physically locking, but, you know, grounding the kid basically for life, and saying she needed to stay in her bedroom because she didn't know what else to do with the child. And I will tell you that we had just started providing telehealth services. I offered telehealth services to this parent at the very beginning, and she said, absolutely not. You know, this was pre-COVID. People didn't believe telehealth worked. And so she was going to make this work. She was going to take the child out of school every day, every week. And she was going to bring them to therapy, and we were going to get them help. And I said, whatever works, you know. And so we set up an appointment for her to come to the office, and they made it about 3 weeks before the barriers started to pop up. And again, this was a very good mother. She was trying very hard. They were a low income family. They did not have great transportation, and that's what started to happen. Her first cancellation was because the transportation, I think the tires, if I remember right, the tires blew or something, and she couldn't get to town. Then after she got the car fixed, then she got offered a kind of a promotion at work, which changed her work hours, which made it much more difficult for her to make that 3-hour trip. And so when you think about that, think about also like it's a 3-hour driving trip, but then you also have an hour of therapy. And on top of that, you have to like go take off of work, go to school to pick up the child. Oftentimes, like there's a meal involved, right? If you're going to travel that far, you got to either pick up lunch or supper. You got to go to the bathroom. Like literally, this was a whole day trek for them. And so again, you know, by about session 6, we had missed about half of the sessions because she couldn't make it, and things were elevating at home and at school, and the mother didn't know what to do. And I was trying to be very, I mean, I was very, you know, my response was just to be very supportive, and I'm here and whatever I can do. But are you sure you don't want to try telehealth? Because she was very staunch that that wasn't going to work, and she was going to get her kid here. And I think part of that was her deep-seated values about like, you know, like, if this is important to me, I will do it, right? And if she tried telehealth, that was like an easy way out, and she wasn't being a good mother. And so I will tell you, like, on about the 3rd session, she said, okay, let me try this. And so, as Nicola kind of just briefly mentioned, we have an iPad loaner program. The family didn't have computers and those types of things at home. And so we loaned out an iPad to the family, and the family rarely missed. And within 6 months, because it's a 6-month treatment, she graduated from treatment. And I'm just really proud to say, not only she had evidence-based treatment, she received it by a distance, and we provided types of things to help overcome those barriers. But this girl was getting good grades in school, like she was getting A's and B's. she had made 1 or 2 friends that she was like regularly doing normal things like going to the movies with or having them over. She was no longer grounded at home. She hadn't had a sexual behavior in over 3 months. And I remember at the closing session, her mom just cried to me, and the girl did as well, but just said to me, like, you gave me my daughter back. And, I'll just be forever grateful for the help that you've been able to offer. And I just really made sure to let her know as well that this happened and this worked because she put the work in. Like the mom followed the suggestions and followed the resources, and the child did what they needed to do to be successful. And then from the last time I heard them, they're still doing very well. And so, Nicola, your turn.
Well, should we open if there's any questions about that case before I share my case specifically?
One of the things that I would say, if you're thinking of questions, one of the things that we really try to do with all our families that we see is not only like we do the screener, we use the evidence-based therapy, and Nicola briefly touched on it, but we really try to help the family overcome those barriers. We do those intensive engagement strategies, right? And so oftentimes that's doing like a needs assessment or scanning for what kinds of things would stand in way or make it difficult for them to complete therapy. And we help them figure out ways to overcome that before we start therapy so that they can be much more successful once therapy starts, and they can really, get through therapy in a very concise manner versus like coming to a session, then missing 3 and then coming, so I think that's been a strategy that's been very helpful to us.
I guess I just have a general question versus like when you're seeing families versus like in home, or like do you go into the homes at all, or is it always like in your guys' office or via telehealth?
At my program, we do not go into the homes. I don't have the capacity for that. So we either do in office or telehealth, but we have done like family therapy over telehealth.
Okay. And then do you see a difference in like success or I guess any progression when you're telehealth versus like in-person therapy? Or is it pretty equal?
I think it depends on the family. I will say that there's some families where the treatment progress is actually quicker because your research shows that you're less likely to miss appointments. And so you're going to get through therapy quicker because you're doing it in the home. You don't have the barriers of weather and transportation, those types of things. You're doing it right in their space. And so research does support that. And we definitely saw that, especially like over COVID. Families, were attending in those types of things. I think post-COVID, we had this kind of little bit of like, I think people were just really unsure about their lives, and like that there was this disorganization maybe of our brains a little bit post-COVID. But I think we've definitely, I feel like my own agency has gone back to seeing it go through quicker. But there are some families who struggle with it. You can't say telehealth is the solution for everything. But it is an option, and it does help overcome a lot of barriers. And so for those families where they just can't figure out the technology, or one of the things that we require with telehealth is that there's a caregiver in the home that's present, not during the session, but present like outside the room in case there's an emergency. And so we do it because of emergency type situations, but I have noticed with specific populations, especially those kiddos who have like impulse control kinds of things, or they're very oppositional. If the parent leaves, like they go grocery shopping or something during the session, even though we ask them not to, those kids will have a harder time staying on task and being on camera, pretending that the equipment's not working, pretending their mic's not working, those types of things. And so it's really another reason, I think, to be able to say to the parent, can you come in and help Johnny cooperate, today. And so, but for the most part, I think I don't know if I prefer one or the other. I think they both really work. And a lot of it is family preference and what works for the family. Sorry,
Perfect.
therapy dog's trying to tell me something.
Thank you.
Goodness.
No, I think the bottom line is that progress can't happen unless you come to therapy. And so, I think that if you come to therapy because it's over telehealth, progress will happen. And if you come, if it's over in person, progress will happen. And I think where you see the differences is maybe when somebody is doing a hybrid, and you get to see, them in both settings, and you see maybe that their engagement is maybe better in person versus over telehealth. And so, I think sometimes the thought is that you have to choose. Are you going to do it in person or over telehealth? And we've challenged ourselves to think about telehealth as a tool to overcome barriers. Like today, in Fargo, the weather's not good. And so I have some kids who like to come in person. They prefer in-person therapy. They are very avoidant kids, and they don't do as well over telehealth. But instead of missing a week of therapy, we will use telehealth as a tool to stay in contact, to stay on the path, and not lose that momentum. So I think that there's ways that we can utilize telehealth even in situations where that might be not the preferred method of therapy, but we can still maintain that progress because we have contact, and maybe it's just not as long because the attention and the engagement is a little bit more difficult for some kids. So I think there's pros and cons, and it works better for some and better for others. And for some it works better because they're there and they would be there.
Can I add to the other thing that we learned, and we really practiced is that when we started telehealth, at least at my agency, we ended up ruling everybody out because we were like, oh, they're ADHD, they can't do telehealth. Oh, they're too young, they can't do telehealth. Oh, they have violent behaviors, they can't. Like, we ruled everybody out. I was like, we're not seeing any telehealth clients. And we really learned that you shouldn't rule kids out. If that's their only access to therapy, then it's our job to make accommodations. So that ADHD kid, maybe we need to send them a fidget or help get them like one of those seat pads so they can kind of rock back and forth, right? And so even then with COVID, we learned to do telehealth like with 3-year-olds. And again, would a 3-year-old be maybe better served in person? Sure, if that's an option. But we have such rural counties in North Dakota that the only option they might have is telehealth. And if that's the only option they have, then I feel it's an ethical responsibility to me to at least try. I can't say it didn't work if I didn't try, right? And for a 3-year-old, that might mean that I'm doing therapy with the kiddo on mom's lap, and the mom's learning the therapy and kind of that coaching style, right? Like, there might be different kinds of things that we do, but if telehealth is the only option for them to have access to therapy, then I'm going to try it. I think kids always have that right, or should have a right, to be able to have access and to be able to heal. So.
Right. So my case example is a little similar in some ways, and it kind of demonstrates that complexity of systems involvement. So I had a kid who was hospitalized. She was a Native American kiddo who was in foster care, and so she was hospitalized and discharged into a foster care home off of the reservation, but still an hour away from a lot of her medical appointments. And I had seen her while she was in the hospital, and so we wanted to continue her trauma treatment with me on an outpatient basis because we'd already built that relationship, right? And so she had to have some medical appointments in town, and so this was before we had our telehealth program. This was before COVID. And telehealth wasn't really a common practice, and it wasn't something that I had been trained in for TFCBT yet. And there wasn't a provider in her area that provided the treatment that we were doing. And so, and her foster parents were were nurses and they didn't work in town where they lived. And so that they worked out of town and they were not able to bring her to appointments. And so it was her case manager's job to bring her to appointments. And so her case manager would every week drive several hours from the reservation to pick her up from her foster parents' home and bring her to her therapy appointment, attend their therapy appointment, and bring her back home, or bring her to the next doctor's appointment, and then drive several hours back to the reservation. Now, that's a lot of time for one kiddo. And when you've got a lot of kids on your caseload, you don't really have that many hours a week. And so what do you think happened? That kiddo didn't come to therapy every week. And so the progress that we had made started to get lost. And it was like we would be seeing each other every 2 weeks. And then we were seeing each other every 3 weeks. And then soon it was like I was only going to see her once a month because it was too much for the caseworker to bring the kid every week or every 2 weeks. And at the time, we had a good relationship, but she was super avoidant. And we weren't going to be able to make the progress needed for us to actually get through treatment, because trauma treatment, you have to work on avoidance. And to work on avoidance, you need to have exposure. And to work on exposure, you actually have to go to therapy. So what ended up happening was we went through our telehealth training, and I ended up doing treatment with her over telehealth, and she was right on the cusp of the age range that we were aiming for. And I tried it anyways, and we did it from school, and then we transitioned to doing it at home. And she did fantastically, and she graduated, and then she was doing so well, and one of her siblings needed to be taken in because something happened with the home that he was in, and her foster parents, things were going so well that her foster parents decided for him to come and stay with her. And so then she had her brother come and stay with her. And then I started to see her brother because she could tell him how wonderful therapy was, and he was super avoidant and shy, but he was able to go off of what she was saying. And so this ended up rippling effect to him, right? And he was successful as well over telehealth. And so just the reality that, these two kids ended up getting the services that they probably wouldn't have got otherwise, because it was impossible for that caseworker to maintain bringing them to services with that setup being the way that it was. And so, utilizing tools like telehealth to reduce barriers, expand access, and to promote healing has been critical as we seek to better serve the rural area that is all over the state that don't have necessarily providers in their counties. So that's really what we have for you. And we will leave open the floor for questions and discussion about kind of these cases, if they sound familiar to you, if you have families that you think would benefit from your services, if you have thoughts about, how do we refer, we are open to any questions that may come up.
Welcome to just unmute and ask.
Yeah, that's fine.
It was brought to my attention that the pre-test that I had was for harm reduction, so not for this presentation. And the post-test and evaluation look the same. So I'm not gonna put that in the chat today. You should get an email with hopefully the correct ones then. Because I don't know, the ones that I have are not right, and I don't know how to find the right ones. So I will not bug you with those links, but I will put the next echo is December 18th with co-occurring disorders in adolescents, and you can register through that link that I put in the chat now. But yeah, sorry about that with the tests. So
Sorry,
hopefully
we
we
did
get
not
the
talk
right
about
one.
anything related to harm reduction.
Yeah, I'm like,
Oh, I could not talk about the answer.
that was not the correct one. So we'll just hope that it gets sent in the email correctly. But yes, no, that was very good information. I do think that I work normally with I'm with the North Dakota Brain Injury Network, so I found a lot of that telehealth has really come a long way, especially since COVID and helping everybody throughout this state. So yeah, it's kind of a blessing and a curse all at once, but it does really make a difference in families everywhere. So
I have a question. What is like the average length of time that somebody goes through this, through your therapy? Is it years or months, or does it just depend on? And then, insurances, are they paying for this well, or is there prior auths that need to be done, or how is that working?
I will say at my center, so all these evidence-based therapies that we shared, none of them last longer than 6 months. Most of them are more like the 4-month lengths, but I tell families to think about like 6 months of therapy because there's always some holiday or vacation or sick or, I mean, there's always some sort of no-shows or cancellations in there on both sides. And so I always tell families like think about like 6 months, the next 6 months. And so so that for us, that would be the average length of treatment. And as far so children's advocacy centers, my CAC anyway, we bill for services, but if insurance does not cover it, we write off the entire rest of the amount. So families never receive a bill for the services that they receive here. We really, I mean, we're a nonprofit, and part of our mission is that if they're coming here, they're already under a lot of stress, and obviously trauma's happened. Like they have enough weight on their shoulders that we do not need to add to that. And so yes, we take Medicaid, and we have some contracts for services. We have some grants that cover services, but we don't ever bill families. So if a family came here and say, I don't know, like say, the bill was, I'm just going to use $100 because that's easy. And Medicaid paid 25 of it, and that's what they had, we would write off 75. We don't charge a copay or anything. I think it's a little different for Nicola's clinic.
I work for Sanford, so I will, no idea. They bill insurances, and I'm not sure the agreements that happen and what's in place. But insurance generally pays if they cover mental health treatment, they'll cover for this treatment. And I would say that generally the goal is 6 months. Sometimes when it's more complex and there's a lot of safety concerns, we can go longer. But the goal is that we would be done in 6 months. We do take Medicaid.
thank you both for your time today. That's very interesting. I found that very informative. Anybody else have questions? Okay, yeah, just wait for your email. Hopefully we'll have the correct links for your post-test and evaluation so you can get your credits. Thank you much for your time.
You guys have a good day.
Thank you.